Welcome to this seminar on improving mobility disability through pain management. My name is Herr. I'm professor and associate dean for faculty in the College of Nursing at the University of Iowa and also the co-director of the Iowa SOME Center for Gerontological Excellence. I'm happy to have this opportunity to share some evidence-based recommendations and information related to pain in older adults. I don't have any conflict of interest to disclose except research funding. And what I want to cover during this time is to talk about the importance of and approaches to pain assessment in improving mobility disability in older adults, talk about approaches to develop a treatment plan for older adults to help maximize mobility and function, and to share some evidence-based resources that can support assessment and management of pain in older persons. First, let's start with looking at the prevalence and impact of pain in older adults. I wanted to share this study, which is from the National Health and Aging Trend Study. So it's a large database, a national sample of over 7,600 older adults. And what was found in this analysis was that over half of this sample reported pain that was bothersome to them in the last month. And that was consistent across age group and across cognitive performance, whether or not the individual reported or had a proxy report, whether they were in a residential care or in the home community. Also, the prevalence was higher in women, those who were overweight, and those who had musculoskeletal conditions or depression. Also of import is the number of sites for pain. So 3/4 of the sample that reported pain had multiple locations or problems with pain, which makes it even more complex for us when we're looking at assessing and treating that. And then of real importance, given this talk today on impairments in mobility and disability, is the pain was significantly associated with decreased physical function. I wanted to also indicate the prevalence of pain by specific site from this study also as evidence of the locations for pain that are most bothersome. And what you'll see here is that most of these are musculoskeletal, which can be impacted by movement, thus very strongly related to function. So clearly, pain problems in older adults are going to contribute to functional impairment that needs to be addressed. This was another study that was done by Joe Shaga looking at the impact of pain on function, and what you can see from the graphs is that there is, if you look at the cognitively impaired group, over 110% increase. I wanted to also indicate the prevalence of pain by specific site from this study also as evidence of the locations for pain that are most bothersome. And what you'll see here is that most of these are musculoskeletal, which can be impacted by movement, thus very strongly related to function. So clearly, pain problems in older adults are going to contribute to functional impairment that needs to be addressed. This was another study that was done by Joe Shaga looking at the impact of pain on function, and what you can see from the graphs is that there is, if you look at the cognitively impaired group, over 110% increase in the need for help with IADLs and a 50% increase in need for help with ADLs in the cognitively impaired. And in the intact group, 60% need more help with IADLs and 33% need more help with ADLs. So what this shows is that those with pain have substantially greater impact on function. Looking at that from a broader perspective, we know that untreated pain or ineffectively treated pain in older adults has significant consequences. It can impair sleep, it can interfere with the ability to get adequate nutrition, it interferes with the ability to engage in meaningful social and recreational activities that can be really important to older adults. It has significant consequences on physical functioning. We know that rehabilitation is impaired and that older adults with pain are also more likely to have falls. And then finally, looking at the affective component, ineffectively managed pain can contribute to depression, anxiety, and can actually increase cognitive impairment. So all of these are elements of function and quality of life that can be impaired with pain that's not effectively recognized and treated, and then contribute to increased healthcare costs and utilization as well. So untreated or ineffectively treated pain is a problem for us, and it's an ongoing challenge to maintain mobility in this population. And we're going to focus on the importance of assessment and identifying the causes of pain that can be treated that impact function, and what are some recommendations for best practices for managing that pain. So let's start with some general principles of assessment. The best indicator of pain in all populations is self-report if we can get it. In older adults, it's important to try to at least identify if there is pain or not pain. We can do that using simple approaches, simple questions, and using synonyms other than pain. It's not uncommon for an older person to say they don't have pain, but if we ask, well, do you have discomfort or soreness or aching? Oh yeah, my hip has really been bothering me. So we need to be a little broader in the way we ask about pain. And it's important to assess pain on every interaction or on a regular basis with older adults. So for a long time we have focused attention on evaluating the intensity of pain as a good marker and a guide to help us with our treatment planning. But there's more, and we've always looked at impact on function, but now we're seeing even more emphasis on the importance of function, or the interference of pain on function and quality of life, and we're going to talk a fair amount about that in our assessment topic today. So it's important to be thorough in an initial assessment to try to identify the treatable contributing factors that might be addressed related to pain. An interdisciplinary approach using team members that can contribute to both the assessment and the treatment plan is also key, and we'll talk a little bit more about that down the road on this presentation. And then the role of the patient in patient-centered care, and involving and collaborating with the patient to establish realistic comfort and functional goals. I think in the past we may have tried to communicate that we want pain to a zero, but I think with chronic pain we've learned that it's often not possible to completely eliminate pain, and our goal should be to reduce pain at a level that allows function and improves quality of life. So a 30% pain reduction is seen as significant and can be a good guide, but establishing that and specific targets with the older adult is going to be key. This slide is just an overview of kind of the comprehensive pain assessment that needs to be done, especially in older adults that have chronic pain. So as I mentioned, first determining the presence of pain, and you can see the tools or the types of things that we look at here. So self-report and using behavioral observation to evaluate pain and its presence. Looking at the medical, pharmacologic, functional aspects and information that impact pain-related concerns, and those can be done through physical examination, an evaluation of medication profile, looking at factors, physical concerns, sensory impairments, functional assessments. We're going to talk about those in a minute. And then what are some of the psychosocial factors that contribute to the pain complaint? And there are a number of different assessments and screens that can be done to help identify issues and concerns here. So we'll be talking about all of these, but this kind of gives you the big picture of what's important in the assessment. Because one part of the assessment process is to try to obtain self-report of how severe pain is. It's important to use valid and reliable tools, and this slide just highlights several of the different options that are available for use with older adults. The top three are verbal descriptor scales that can be a simple way to get information on the severity of pain, such as none, mild, moderate, or severe. It can be very easy to use. There is also a numeric rating scale. We use the vertical version in older adults because it seems to help with conceptual thinking. On the left is a tool that we developed called the Iowa Pain Thermometer, and it aligns a verbal descriptor scale with a thermometer that can be helpful with abstract thinking. So as temperature rises, pain increases, and sometimes that can be helpful, and it's actually been a preferred tool by older adults. And then on the right is a FACES pain scale, which is another option where the individual looks at the faces and picks the one that represents how severe their pain is. You do not use this tool by having the nurse or the CNA look and identify which face the patient is making. That's not the purpose of this tool. We also, in the studies that have been done looking at preferences of pain scale, the FACES pain scale has been chosen often by individuals that are African American, Asian, and Hispanic. So it might be a good option to have for those populations. We have done some follow-up work with the Iowa pain thermometer to revise it to make it align better with the 0 to 10 scale in the clinical environment. And so this is just a simple scale that combines the descriptor scale, numeric scale, and the thermometer. In studies that we've done comparing this with other scales, it is the preferred scale over the numeric rating scale by the majority of intact and cognitively impaired older adults. So it's another option that could be integrated into your clinical setting. So do we have tools that are reliable and valid to use with cognitively impaired older adults? This is a study that illustrates the ability of this population to use scales. And if you look at the graph, what you see is on the left is the pale gray bar, is the numeric rating scale, and has cognitive impairment increase, as you can see the different levels along the h-axis. And you'll see that mild, moderate, cognitively impaired, you start seeing decreases in the ability to use the numeric rating scale. But the verbal descriptor scales, two different types, you can see most cognitively impaired, even those with moderate cognitive impairment, are able to report their pain on a simple VRS. But by the time you get to severe cognitive impairment, it's not possible to use these types of scales. So you might want to screen for cognitive level to kind of get a sense of where the person is. If they have dementia, that might be impacting their ability to self-report reliably. The mini-cog is a simple screener that you might be familiar with that just uses a 3-word recall and a clock draw as a distractor, and you can determine whether or not the person is likely to have dementia, and if so, you could follow up with a more in-depth screen or evaluation. But the key point is to remember that even those with moderate cognitive impairment are able to self-report pain, so we should still try to get that when possible. So it's particularly relevant for this talk because we're talking about trying to maintain mobility and function. A good assessment of the impact of pain on function is key. These are some of the categories of function that we are interested in. Their ability to do normal activities and activities of daily living, to be able to sleep, good appetite, energy level, whether or not they're able to do exercise, engage in other activities such as watching television, interacting with others, how pain interferes with mood. Is there evidence of depression or anxiety? Can they interact with others and participate in activities? And are we seeing changes in cognitive ability? And there are ways that we can assess and monitor for these through standard scales and impact scales that we're going to talk about. So the VA did some work in developing a quick screener that they could use in the acute care setting, and I think they also use it in some of their community outreach clinics as well. But on the right is a scale called the PEG that was developed by the VA, and it's actually 3 items from the brief pain inventory, which is a longer scale that's been used and tested in older adults as well. But the 3 questions simply look at the severity of pain in the past week, how much pain interferes with enjoyment of life, and how does it impair overall general activity. And those 3 items were strongly related to other tools, but yet a short way to kind of zone in on some of the key factors that we're interested in. So that's an option. Another one is the functional pain scale, and this tool was developed by Michael Gloth for use in a community setting, and it looks at how tolerable pain is to the older person. And so they rate their pain on basically interference with the ability to do activities such as talk on the phone, watch television, communicate and interact with others, engage in normal activities. So it kind of melds pain severity with impact. This has been adapted in this format at Mass General Hospital, and this is a version that they use that rather than defining specific activities, talks about active ability to engage in active activities versus passive activities, such as just lying in bed and watching television would be a passive activity, but getting up and ambulating would be an active activity. So it's important to identify or screen for problems that could contribute to the chronic pain experience and that might be able to be addressed to help with chronic pain. So mood is one of those that we want to screen for. The PHQ-4 is a screening tool that has 4 items that are asked of the older adult. Over the past 2 weeks, how often have you been bothered by interest or pleasure in doing things? Feeling down, depressed, or hopeless, those are screens for depression. Feeling nervous, anxious, or on edge, or not being able to stop or control worrying, those are screens for anxiety. If these are positive screens, then we would want to refer for more detailed evaluation and treatment of those issues. Some other topics that are important in the evaluation is to look at pain coping. Does the person feel that their pain is terrible and it's never going to get better? It gives you an idea about their frame of mind and how well they might be able to cope with pain. Fear avoidance. Older adults are often afraid of hurting themselves worse. So asking them, it's not really safe for a person with my pain problem to be physically active. Do they agree or disagree with that? That's going to be important when we're looking at physical activity interventions. Asking them, do they think their pain will get better? Understanding their thought process about whether or not they're going to be able to control pain or improve pain is also important, and there are things that we can do to strengthen that. And sleep. We know that sleep is comorbid to chronic pain, about a 30% comorbidity that can cause pain, or pain can cause impairments in sleep. So we need to understand what their sleep experience is. So asking, do you feel you get good quality sleep, is important. I wanted to share an approach that was developed at the University of Utah called the Clinically Aligned Pain Assessment. And this is an interview with patients. So it's moving away from using the 0 to 10 scale to look at pain severity, but rather to talk with the person about what they're experiencing. So asking them questions about how tolerable pain is relative to comfort. What changes in pain are they experiencing? Is it better or worse or the same? How is pain control? Are they satisfied with what's being done right now, or do we need to try to adjust the treatment plan? How is pain impacting their function? What changes are we seeing there? What can they do or not do? And how is pain interfering with their sleep? So it's a guided interview, and then the nurse rates pain according to the responses on the right. So it's a more engaging, natural conversation with patients, and patients really have preferred this over using a self-report scale. Nurses have preferred it because it's back to more engaging in conversation with patients, and it's been shown to be more effective in classifying the pain problem and in evaluating how patients feel about their pain control. Significant improvements in the Press-Ganey scores in this hospital when they did some preliminary testing. There's not a lot published on it yet, but it's one approach that you might consider. So there's also an approach that I wanted to share with you called the hierarchy of pain techniques that can be used across populations, but it's used in particular with older adults who are not able to self-report. And it starts with self-report because you still want to try, even in cognitively impaired older adults. But if they can't tell us what they're experiencing, then we have to use other mechanisms. And that includes looking for potential causes of pain, evaluating pain behaviors through the use of reliable and valid pain behavior scales, getting input from surrogates or proxies about their pain experience, changes in behavior that might indicate pain. And if we think we're seeing pain but we're not sure, we can use an analgesic trial to evaluate if behaviors improve when we treat them as pain-related. So this is one approach that can be used to guide us in gathering information about pain. So in looking at potential causes for pain, a physical exam and a good history is really important to look at locations of pain that might help us to understand the etiology. Look for pathological conditions or common procedures that are known to be painful. So is there evidence of infection, such as a urinary tract infection or pneumonia? Are there skin impairments, such as incisions that haven't healed well, skin tears, old fractures, irritation, chronic constipation can actually be a painful condition that could be easily, maybe not easily, but could be addressed. Procedures, surgeries, wound care, rehabilitation activities, repositioning and turning. All of these things are conditions or activities that could be causing pain. We also look specifically for sites of pain and pain referral, focusing on the musculoskeletal system and the neurological systems. As we noted earlier in this presentation, many of the chronic pain problems are musculoskeletal related, so evaluating those. It might be helpful to do laboratory and diagnostic test analysis, but especially with older adults, we should be cautious and only do invasive procedures if indeed it's going to change the way that we might treat the person. And then looking at coexisting diseases and their medications. Older persons have many comorbidities such as cardiovascular disease, renal disease, liver impairment that have an impact on the pharmacologic management of pain in particular. And a medication review is critical to look at what they're already taking to help us to evaluate potential for drug-drug interactions and also adverse effects from some of the medications that we might use for pharmacologic management of pain. So this slide just highlights some of the common pain conditions in older adults by disease. So you can see those that contribute to nociceptive pain, such as osteoporosis, spinal stenosis, arthritis, previous fractures, neuropathic pain conditions, such as polyneuropathy from diabetes, postherpetic neuralgia, herpes zoster, post-stroke pain, trigeminal neuralgia. Both of those types of pain are going to be treated a little bit differently because of the mechanisms of the pain. And then there's conditions that are mixed, where you have both nociceptive and neuropathic pain components, such as CRPS, fibromyalgia, and migraine. So these are just some examples of pain conditions that we should be alert to when we're doing our baseline assessment. So let's look at common pain locations that were identified in a large study of 2,400 older adults, again a national database. And what was found, similar to the earlier study that I showed you, was that 60% of older adults had multiple pain sites, 50% had moderate or greater pain in the past 4 weeks, and women showed more intense and frequent pain than men. And you can see the common locations. Again, most of these, all of these that are on this slide actually are musculoskeletal. And there's commonalities across genders, but clearly legs and back are areas of high pain prevalence in older adults. I wanted to share this slide with you and these resources. There's a wonderful series in pain medicine that focuses on deconstructing chronic low back pain in the older adult. And it's a series of 12 different papers that look at the different causes of chronic low back pain and details an algorithm for assessment and treatment that's specifically targeted on each of these potential causes. It's a really well done series, and I think you might find it useful to access some of these. So what about the person who can't share self-report with us and provide information about their pain? We really don't have a lot of options. Assessment using nonverbal pain tools is one of the ways that we try to get information about pain in this population. There's over 25 nonverbal pain tools available. There have been a lot of reviews of these tools. And there's no single best tool for all settings. And so we really need to evaluate what we use based on our setting and our population. I'm just sharing a few of them as an example. So this is the PAINAD, which you might be familiar with. And you can see there's 5 categories of behavior: breathing, negative vocalizations, facial expression, body language, and consolability. That's rated on 3 different levels of intensity. This is another one called the PAC-SLAC-2. There are more behaviors on this scale. I think this one has 31. And also includes some behaviors that relate to changes in behavior. This has been tested and used in a number of different settings as well. It's just a check of, is the behavior present or absent? So picking a tool for your setting is important, and incorporating it into regular use so that you have baseline evaluation, and then you repeatedly use those same scales over time, looking for changes that might indicate increases or decreases in those behaviors that are pain related, suggesting that pain might be getting better or worse. We also have studies recently that have been looking at interventions that target pain or behavior and depression, such as agitation and aggression and depression. And when we treat those behaviors as if they're pain-related, we are seeing significant improvements in them, suggesting that there is a strong relationship of these types of behaviors with pain and need to be considered potential pain-related causes. I just wanted to share that there's ongoing work. I told you that we have at least 25 different tools. There are 2 groups that have been trying to look across the different tools to identify sets of behaviors that are most predictive of pain and pain severity in the population of dementia. So there's a group in Europe that have developed the Pain Assessment and Impaired Cognition meta-tool, and I'm working with a group that's developed pain intensity for persons with dementia. Both of these are trying to develop, look more specifically at the specific behaviors that are most important in recognizing pain and monitoring for change. So you should be seeing more about these in the literature in the near future. I just also wanted to share this tool that a student who's now postdoc, Stacia Booker, and I developed in a publication on assessing and measuring pain in older adults. And I'm not going to read it, but it talks through what are some of the differences in the steps of assessment in the cognitively intact older adult who can self-report and the cognitively impaired who can't. And it basically goes through the hierarchy, but illustrates some of the differences about how you need to approach each of these groups of older adults. So in looking at the assessment information that we've been talking about, part of the comprehensive assessment is to try to identify modifiable targets that could be treated, such as the presence of a sleep disturbance, someone who is not physically active, someone who is overweight or obese, who is experiencing social isolation or depression or negative mood, who is not finding enjoyment in life, or who has fear avoidance beliefs. These are all factors that can impact the treatment plan and the effectiveness of a treatment plan for chronic pain management. So each of these, when identified, should be followed up with specific targeted treatments. There's other information that's important to guide our treatment plan in the history, and the first of these is their analgesic history. You know, what have they used before to manage pain? When we're talking about older adults, they're at least 65 years or older and have had a long life and had probably multiple experiences with pain. So what have they found effective? What analgesics have they used, or what have they used that they would never use again because of the side effects that they experienced? That's really important to help us in looking at what our options are. We know it's really important to look at over-the-counter medication use of older adults. This is particularly critical when we're looking at acetaminophen as a treatment option because it is embedded and included in many over-the-counter drug products. It's in sleep aids, flu aids, analgesics that the older person might be taking, and we want to make sure that we're not adding to medication they're already taking and putting them at risk for a liver impairment because of overdose of the max capacity for acetaminophen. Alcohol use or abuse is another important area because we know if they are active drinkers, it is going to impact their experience of analgesics and potentially put them at risk for respiratory depression or other adverse effects. It's also very important to get information in the history about past treatments and their effectiveness, including home remedies. We need to find out what they've used and what's helped them in the past. They've had many years with probably dealing with pain problems and have used things that have been helpful. So if we can get that information, we can integrate those treatments into the plan of care. Something that's relatively new is screening for risk for opioid addiction and or misuse. With the occurrence of the opioid epidemic in our country right now, the concerns about opioid use have increased, and it's not that we can't use them, but we do have to be more cautious, and identifying patients that are at risk through a screening approach will help guide us as to what approaches in education and monitoring we need to integrate into the plan. So let's talk about treatment considerations now for persistent pain in older adults. Our goal is to provide optimal pain relief that maximizes function and quality of life, is the safest treatment plan and the most efficacious treatment plan, and we balance that against the risks of different treatments, how tolerable they are to the older adult, and the patient characteristics and comorbidities that impact whether or not certain treatment options can be used. The approaches to developing a treatment plan are to focus on interdisciplinarity. Involvement of different members of the healthcare team can be very valuable. As I mentioned earlier, our treatment plan also needs to be patient-centered. We have to find out what their goals are and then how open they are to trying different treatment options, which can be really important, especially when we talk about some of the non-drug options and some of the medication options as well. I've already talked about the importance of a quality assessment to provide the foundation for the treatment plan. And optimizing non-drug approaches, and actually this is moving up in the hierarchy of approaches and considerations. We're going to talk a fair amount about that soon. Balancing risk benefits and optimizing the treatment plan to minimize adverse events, misuse, and abuse. It's also important as a part of the treatment plan to monitor and document outcomes so that other providers have a way of helping to evaluate response to treatment, what works, doesn't work, what changes may be needed, and what things we can recommend in the future. So as I mentioned, optimizing non-drug approaches has been recommended in guidelines, mostly because of the opioid epidemic and some of the adverse effects we're learning about opioids, to make sure that we're using the safest approaches first when we develop a treatment plan. So I'm going to share some guidelines. This is the most recent guideline on pain management in older people, which was published in 2013 by the British Pain Society and the British Geriatric Society. And they provided recommendations that are non-drug and either has adjunct or first line, and you'll see their recommendations for psychological interventions, for assistive devices, exercise and physical therapy, self-management approaches, and other complementary therapy such as acupuncture, TENS, massage, reflexology. These are all approaches that are relatively safe in older adults and need to be considered, particularly when the problems, when we're dealing with chronic pain issues. So since the opioid epidemic, there's been a lot of attention by a number of organizations on ways to minimize the prescription of opioids and their misuse. And those have led to new recommendations about approaches to pain management. Now, I want to mention that these 4 guidelines were not focused on older adults. They basically cross all populations. But some of the evidence within them that supports care of older adults is very limited, which we'll talk about. So there are guidelines from the CDC, the VA, the American College of Physicians, and the Joint Commission. And so all of these are within the last 2 years, and I'm going to share kind of the highlights related to treatment approaches. So the CDC guidelines focus on non-pharm approaches, has preference for reducing pain and improving function, that we should encourage patients to adopt self-management approaches such as exercise. The CDC also recommends that non-opioid pharm therapies should be employed, but only when the benefits outweigh their risk. And a point of consideration is that it's difficult to know the full range of risks and benefits because they haven't really been identified and studied adequately. The VA guidelines actually specifically state to avoid initiating long-term opioid therapy for chronic pain, use alternatives such as self-management approaches and other non-pharm approaches, and if opioid therapy is prescribed, use only a short course and assure that the dosing is under 90 milliequivalents per day. The ACP guidelines also suggest non-pharm approaches should be used and that this should be the initial treatment approach. They have strong recommendations, again, for non-drug interventions, exercise, mindfulness-based techniques, acupuncture, CBT, Tai Chi, yoga. And if an inadequate response to any of these, then start drug therapy. with first line being NSAIDs and second line being duloxetine, which is an antidepressant. Again, these recommendations are across the board for chronic low back pain, not targeted or based on evidence for any specific population. And then the Joint Commission standards have been revised, and these are inpatient at this point. And they recommend now non-pharm treatments need to be provided. The staff and practitioners need to have educational resources and programs to improve the use of assessment and management practices. That we should improve assessment by focusing more on how pain affects patients' physical function. And patients should be encouraged to engage in treatment decisions regarding pain management. So these are all new recommendations in the last couple of years. So looking at the consensus of the recommendations across these new guidelines, there's strong encouragement for non-pharmacologic approaches. If those approaches are insufficient, clinicians should then initiate non-opioid therapy with an emphasis on nonsteroidals, SNRIs, and anticonvulsants. Hospitals must provide access to non-pharmacological treatments. Recommendations for adults are made irrespective of age. This is a little bit of a concern given that there's limited evidence on older adults, particularly the older old, related to some of the interventions. And these guidelines do represent a paradigm shift for us in that because of concerns with NSAIDs in older adults in particular, opioids placed a stronger role in the treatment plan. Now the use of opioids is a little bit lower in the treatment consideration for older adults and has to be weighed carefully against a risk-benefit analysis. So Stacia Booker and I developed a framework for persistent pain treatment in older adults, and it highlights on the left different levels of pain severity and impact on function. And you can see foundational is self-management complementary treatments, and those include the non-drug interventions. And at level 1 with mild pain, if analgesics are needed, starting with acetaminophen or topical counterstimulants. And then as pain becomes more severe or is not responsive to some of the treatments at level 1, topical NSAIDs can be used. Other adjuvants that were mentioned earlier, such as duloxetine or gabapentin, might be appropriate. And again, the choice of intervention, pharmacologic intervention, has to be tailored to the person, their unique characteristics, the pain type and location, and comorbidities that need to be considered. And then level 3 would be severe pain that's not responding to treatments at the lower levels. And this is where the consideration for NSAIDs and opioids might be needed, as well as interventional techniques. I think it's really key when we think about a framework for treatment in older adults that the goal is to always very carefully evaluate risk-benefit of our treatment options and take into consideration some of the points that I talked about earlier. I mentioned the interdisciplinary team and its important role in managing medications and implementing non-drug treatments and promoting ADLs and addressing psychosocial issues, which are all important in the older adult. So with the patient in the center and sometimes the family member with the provider, it may require reaching out to specific groups. Nursing can play a really important role in contributing to assessment and treatment. Also, occupational therapist, physical therapist, pharmacists can play key roles. Some of the other specialists that I've identified here may need to be called in if we have to do more in-depth evaluation and interventions. But it depends on the person and what their unique situation is as to who we bring into the team at any given point in time. So we do have reviews of evidence about non-pharm approaches to the management of chronic pain in community-dwelling older adults. There's also studies that have looked at complementary therapies, and across the board what we find is of the self-management options that were mentioned earlier in some of the guidelines, the ones that we do have the strongest evidence for use in older adults is exercise. There are randomized control trials looking at the use of physical therapy, therapeutic exercise programs, yoga, tai chi, and cognitive behavioral therapy that involves a more structured approach to helping the individual to cope with pain. There are nice studies in older adults. Other areas where we do have some evidence are thermal treatments, assistive devices, use of TENS and acupuncture and massage, also mindfulness meditation and some self-management programs, and the use of distraction. We have lower level of evidence, but we do have some studies. Some of the challenges with self-management options with older adults is how do you apply these in the clinical environment, because we often can't use the detailed protocol that's used when we test these in clinical trials. So more research really does need to be done on helping us to adapt these and implement them for older adults. So some recommendations about translating evidence that we have into practice, especially related to non-pharm treatment, is to anticipate and address patient barriers. So if there's skepticism about a non-pharm intervention, it's not likely to be effective, or if they believe that it's harmful. An example of this is the use of guided imagery. Many older adults feel that the thought process of working through imagining being on a beach, for example, and listening to the waves and feeling the heat and smelling the ocean might be too abstract for older people. So we have to find out what they are comfortable with and willing to try. Lack of knowledge about potential benefits of non-pharm treatments is one of our challenges that we're trying to learn more about, but it's important to present interventions in a positive mindset. If the older adult has a low motivation to participate, again, with low treatment expectancy, that's probably what we're going to get. So we really want to try to create a positive anticipation of effect without overly conveying maybe a false expectation of what an intervention can provide. And other barriers are transportation issues and time commitment that come along with some of the non-drug interventions. So we know that physical activity can be helpful. Going to a gym with a trainer and supervision can be really important in successful use of a regular exercise program, but getting to that activity might not work. Tai Chi, organized group Tai Chi may not be possible. So what is available and how can we help the older person to address those issues? Many of the non-pharm interventions do require time, sometimes weeks to months, before we see an improvement. So making sure that it's understood that they've had chronic pain for some time, so we're not going to eliminate it or reduce it overnight. So exercise programs, again, it takes 4 to 6 weeks before we're starting to really see some good effect of that. So it's important to look at adherence and whether they'll be able to comply and complete the treatment plan. Do they have other health issues that are going to interfere with that intervention? Who in the caregiving environment can help implement some of the non-drug interventions? So, for example, a massage therapy on a painful joint can be very helpful in the surrounding tissue. Is there someone that can do that or get them to where they need to go for treatment? And they may be experiencing, as I mentioned earlier, psychosocial stressors or even financial stressors that might impact whether or not they can engage in a non-drug approach. So it's important to talk about the issues that they have that might jeopardize their ability to participate and implement non-drug interventions. Some of the things that can facilitate these interventions is to educate the patient about the rationale for the treatment, that this is now standard of care, that it can potentially reduce the use of medications and the unwanted side effects from that. Establishing positive treatment expectations before initiating the therapy is really important. We know that there is a positive placebo effect that's real, that causes actual physiological changes in the brain, and we can facilitate that by presenting interventions in a positive way. So we don't want to oversell them, but we can say things like, many of my patients have found this intervention to be very helpful with their chronic low back pain. as a way to try to set positive expectations. And then try to provide support and encouragement through local resources. So there are few head-to-head comparisons, as I mentioned. There's no evidence that one approach is better than another. So sometimes it's just a trial with the person to see if this is going to be helpful or not. The treatment effects from studies that have been conducted are often small, and it's not clear that there's going to be a huge improvement in pain relief. So our goal is not to eliminate pain, but to reduce it to the point where it can be manageable and allow engagement in function and mobility activities that are desirable. There are also groups for which we don't have a lot of evidence, the old versus the young old, men versus women in the aging group, and again, whether individuals will benefit from any one particular non-pharm approach. So some resources that you might look at in your community that might be helpful. The Arthritis Foundation often offers locally structured exercise and Tai Chi programs. The Tai Chi Foundation in local communities may offer those programs as well. There are often integrative medicine programs within communities that might have access to some of the alternative therapies that the older person might be interested in trying. The local AAAs, often through senior centers, offer programs related to chronic pain management, such as Silver Sneakers, the Arthritis Self-Management Program, the Chronic Disease and Self-Management Program. These are all well-tested interventional programs that are often offered in local communities. And sometimes hospitals have health and wellness programs for which the older person might be able to join. Some other key considerations are, as I mentioned earlier, establish mutually agreed upon goals that are feasible for the patient to achieve. So rather than saying, let's decrease pain from an 8 to a 6, a goal that would be more effective and focus on what we're really interested in as function is, I want to be able to sit and visit with my grandchildren for an hour without pain being so disruptive. Or I want to be able to walk 2 blocks in a week. So set concrete measurable goals so they can actually see improvement and progress over time. As I mentioned earlier, it's important to communicate that there are no easy fixes with chronic pain management, but that we're going to work together to collaborate and come up with a plan, and that we're there to support them through this process. We need to communicate some of the limitations of pain medications, but yet not oversell the non-pharm approaches. I think we can communicate that it's going to require a combination of drug and non-drug approaches, most likely, and that we want to find the best balance that's going to provide the least risk and the most benefit and the most improvement in function. So educating patients about some of the preventative things, the importance of sustained physical activity to reduce the risk of future disability is critical. Most of the studies that have looked at exercise have shown that there is a direct improvement in pain from exercise. So it's not just the health benefits, it does have a pain reduction benefit, but engaging in exercise to improve activity and also to reduce weight can be an important factor. So some things that we can do to help to motivate patients to engage in physical activity is the use of activity bracelets as an objective measure of physical activity. I know my father, who's 85, uses a tracker to keep track of his steps every day, and he finds that very motivating and reinforcing of physical activity. And so there are a variety of apps and devices that older adults can be using to help promote physical activity. So a few pharmacotherapy points. Pharmacotherapy has limited efficacy and or evidence in chronic pain. So this is a change in our understanding about its use. We used to use opioids more freely with chronic pain, but a lot of concerns have been coming up in the literature and in studies about its effectiveness. So actually what the evidence is that there's a lack of evidence because the studies just haven't been conducted to look at long-term use of medications such as opioids or NSAIDs or any of the medications over long-term studies. Most of the studies are 6 to 12 weeks, which is not exactly what we're talking about with older people that have chronic musculoskeletal pain that is going to last for years. It's probably not going to go away unless they have a joint replacement. So we're talking long-term, and there just aren't studies that have actually looked at this and what are the consequences of that. There is also limited evidence in older adults in particular, and then especially in cognitively impaired. Most of the studies that have tested and evaluated safety and efficacy of drugs have a very homogeneous sample where they've excluded older adults that have comorbidities. So the population that we typically take care of, who does have congestive heart failure, who may have some renal impairment, are not part of these studies. So we also lack evidence there. We do know, though, that the risk of adverse effects is greater in older people, and that's related to the changing physiology of older people, the reduction in renal function, kidney function, cardiovascular health, so they are more at risk. And a risk-benefit analysis is important to determine, though, if therapeutic goals can be achieved. And so medications such as opioids might have a place if the use of other treatments has not been effective. So it's trying least risky things first, and then incorporating opioids down the road if needed when there's an inadequate response. If there's an inadequate response to any of the treatment options that we try, we want to wean those off and try other options that are more safe. I also wanted to share with you medications to avoid in older adults. The American Geriatric Society formed a consensus panel that meets every 3 years to revisit the Beers criteria, which is a list of medications to avoid or use with caution in older adults. These are the 2015 recommendations that relate to pain, and they're actually being updated as we speak, so there will be a new edition out very shortly. But currently we know that medications to be avoided are meperidine, non-COX-selective NSAIDs for chronic use in particular, indomethacin, ketorolac, pentazocine, skeletal muscle relaxants, and opioids to be avoided in the history of falls or fractures, except in pain management due to fractures or joint replacements. So to summarize treatment recommendations, integrate non-pharm approaches initially. Treating pain in older adults does have unique challenges because some of the concerns that are unique to this population. Acetaminophen is considered first-line therapy. Topical agents for localized pain can be used, whether they're counterstimulants such as Bengay or Icy Hot, or local topical NSAIDs such as diclofenac. NSAIDs should be used rarely and with extreme caution in older adults because of the risk not only of peptic ulcer disease and bleeding issues, but also risk for cardiovascular comorbidities. Consider adjuvants for neuropathic pain. We know that antidepressants and anticonvulsants may be more beneficial for that particular mechanism of pain. And consider opioids for moderate to severe pain after other treatment options have been unsuccessful. In applying treatment recommendations for older adults, it's important to apply guidelines, but yet to individualize treatment to the uniquenesses of each patient. It requires the good history that we talked about and looking at the patient's preferences and values, as well as risks and benefits for different treatment options. I just wanted to mention with the cognitively impaired, if we're looking at pharmacotherapy, that the typical approach of using PRN analgesic use doesn't work well for this population because they're often unlikely to ask for pain medications, which is what's required for PRNs. So the use of scheduled medications is more appropriate. It's also important to consult with pharmacy and get input on the potential for drug-drug or adverse drug reactions from medications that you might be considering in your patient. And education is kind of foundational to a successful treatment plan, providing the patient and family with the knowledge they need to be successful in their role in implementing non-drug and drug interventions and to engage in self-management approaches is key. So I have a few slides that I've included for you just so that you can have information about some resources. This slide just highlights the different assessment clinical practice guidelines that are available from the British Pain Society, the interdisciplinary consensus panel that was conducted internationally, self-report on, or the position statement from the ASPMN on pain assessment, and those that are unable to self-report. We're in the process of updating that one, so we should have a new one out soon. These are guidelines that have recommendations for older adults related to treatment. The AGS guidelines from 2009, the Beers criteria, which is also being updated, and the American College of Rheumatology also has recommendations that I referred to earlier. So these can also be used as resources to get more detailed information on some of the interventions. And two more, the British Pain Society and British Geriatric Society guideline, and the American Medical Directors Association also has guidelines on pain management in long-term care. We have an evidence-based practice program here at the University of Iowa in the College of Nursing, and we recently updated two guidelines, one on acute pain and one on persistent pain in older adults. Those can be accessed at the web link here. I wanted to call attention to this resource. So I was co-editor on a special issue that was published in the Journal of Gerontological Nursing on the opioid epidemic and persistent pain management in older adults. And there's some key papers that talk about the issues and challenges of providing quality pain management during this era of opioid misuse and abuse. And we have papers on complementary and alternative therapies looking at the evidence, and also how to use pharmacotherapy effectively. So I would encourage you to look at these resources as well. And then we've also developed with a national group of experts a resource website called geriatricpain.org that is currently centered here at Iowa, but was developed with the help of the Hartford Centers of Geriatric Nursing Excellence. And it is a web resource of best practice tools and resources for clinicians that can be downloaded and used in your care setting. Everything on here is free, and we encourage you to visit and look at some of the resources that are available that can help you improve assessment and management, educate staff and providers, and we've added a new section for caregivers and patients, which have resources that you can download and use to help educate on pain management for caregivers and their loved ones. And then my final slides are just to give you an example of one of the tools there. This is a management guide for joint pain, and so we have a number of management guides for different clinical pain problems. And so we define it, we talk about what issues related to it, the problem. We look at causes, signs and symptoms, and management approaches. We provide a section on physical examination, what you should specifically be looking for in that evaluation. We talk about the nursing care that would be initially appropriate for this condition and what needs to be communicated to the primary care provider through an SBAR communication approach. And then finally, a little more information about treatments and medications with some key references. So we have a series of these, as well as many other tools that I would hope that you might find useful to you in your work to strive for maximum function and quality of life in the older adults that you care for. Thank you for joining us today, and I hope you'll find the information in this presentation useful to you.